بسم الله الرحمن الرحيم. أنا دكتور علي الإمام، أستاذ جراحة الأوعية الدموية. Today our lecture is one of the vascular emergency, which is known as acute ischemia of the extremities. What are the components of acute ischemia? Acute ischemia is known as peripheral arterial disease, which is either chronic ischemia or acute ischemia. One of the emergency of the chronic ischemia is known as critical limb ischemia or CLI. Critical limb ischemia means pain or rest pain and trophic changes in a patient with for more than 2 weeks without response to any medical treatment, or the acute limb ischemia, which is our lecture today. So the acute limb ischemia is in acute form, while the critical limb ischemia is a form or severe form of chronic limb ischemia, and this is the difference between both. Here a picture, very important to differentiate between the acute and the chronic limb ischemia. The acute ischemia, rapid occlusion, no time for collaterals development, no time for evaporation of the tissues, so it is associated with this picture, which is the wet gangrene and edema, and very fatal. And here is a picture of the critical limb ischemia or the chronic ischemia associated with rest pain, trophic changes, but in a chronic patient with collateral, so he developed or the patient developed chronic ischemia, trophic changes. There is a good collateral, and this can be salvaged, while this limb cannot be salvaged because there is no time for development of collateral. This is the acute ischemia with wet gangrene, and this is chronic ischemia with dry gangrene. This is usually can be corrected. This is usually difficult to be corrected. What's meant by ischemia? Ischemia means relative diminution of blood vessels to an organ. What is the acute limb ischemia, which is an surgical emergency? Acute limb ischemia is any sudden acute occlusion or decrease in the limb perfusion in less than 2 weeks, causing a potential threat to the extremity viability. But we know all that the revascularization must be started very early, up to or down to 6 hours, because after 6 hours there is necrosis of the muscles, necrosis of the tissues and nerves and so on. So it's better to be early as possible. But as regard definition, this is any sudden acute decrease in the limb perfusion in less than 2 weeks. If it is more than 2 weeks and not responding to medical treatment, this is a critical limb ischemia, which is one of the stages of chronic limb ischemia. The patient usually presents with the 6 P's, which is pain in the limb, pallor or color changes, pulselessness, absence pulse, poikilothermia or coldness, paresthesia, loss of sensation, and the paralysis, which is a late stage of acute ischemia. The major causes or major etiology of acute ischemia is either acute arterial embolism, and this occurs on a relatively or healthy arterial wall, normal artery, while the acute arterial thrombosis occurs in a previously diseased arterial tree or atherosclerotic vessels, and the other entity is the acute traumatic ischemia. These are the 3 major causes: acute arterial embolism on a relatively healthy arterial wall, acute arterial thrombosis on a previously diseased arterial tree, and acute traumatic ischemia on top of trauma. Arterial embolism, will speak more about this entity, or acute arterial thrombosis. Acute arterial thrombosis on top of diseased vessel, and it is also associated with predisposing factor like dehydration in hot weather, diarrhea, fever, hypotension patients with shock, sepsis, and myocardial infarction, pressure, malignancy due to hematologic factor or hypercoagulability of the cancer state, hypercoagulable state like cases of thrombophilia. Other causes like trauma, intra-arterial drug injection, aortic dissection, external compression of very tight tourniquet, compartment syndrome, and extensive iliofemoral DVT. In extensive iliofemoral DVT, which is called the phlegmasia seriola dolens, Here there is due to the increase or complete occlusion of the venous side of the circulation leads to closure of the capillaries and arterioles, leading to a sort of acute ischemia. Compartment syndrome after trauma due to increased pressure inside the compartment, compression of the vessels leading to acute ischemia, or external compression by tight tourniquet or cast. Here another repetition of the causes which can be classified according to from inside the wall it is embolus. On the wall of the vessel it is either thrombosis or trauma injury, or dissection of the vessel like aortic dissection, or compression from outside like tight bandage, cast, tourniquet, or compartmental syndrome and burn. Here are some pictures of ischemia. This is a traumatic cut rest with complete trauma, complete injury of the arteries and veins and tendons. If these vessels are not repaired, at least one of them, it will be a very critical case of acute ischemia and may end by tissue loss. Another case of neglected arterial injury leading to affection of the arterial supply of the hand. As you see, this patient also operated an fasciotomy to reserve the limb, but as you see there is mottling and starts to be dead limb. Here direct trauma, either direct trauma to the artery or trauma to the bone leading to bone fragmentation and the injury of the vessel can occur. Another case of acute ischemia due to compression. This is patient with closed fracture of both lower limbs, and he did a cast, but the cast was very tight and the patient doesn't know about this complaint. He thought that this is a normal complaint, but after removal of the cast, this is a picture, patient lose his limb because of fracture. So the cast must be very suitable in application. We must know, feel the pulsation before doing the cast. If the patient feels any abnormal sensation, any abnormal complaint, he must ask for the solution. He's the patient, as you see, and end by a very disastrous complication. A case of intra-arterial injection. Patient addict injected some of the drugs intra-arterial. These drugs goes to the microcirculation leading to digital ischemia and digital soft tissue affection like the digital gangrene. Although sometimes of this patient has a distal pulse in the main vessels, but in the distal vessels or the distal digits has no pulsation. And as you see, starts to develop gangrene. The main entity of acute ischemia is arterial embolism. What's meant by the word embolism? Embolism is the passage of a matter from one part of the circulation to another through a vascular lumen. The acute embolic ischemia usually originate from the heart, and the most common cause is atrial fibrillation or irregular pulse, and sometimes with mitral valve affection, either stenosis or incompetence. And usually the acute embolic ischemia occurs at the site of bifurcation, because here the artery starts to be narrow. So the site of embolus is impacted usually at the bifurcation and leads to distal ischemia. The most common site is the femoral bifurcation, followed by the aortic bifurcation, and then by the popliteal artery bifurcation. Here is CT angio showing the acute arterial embolism with occlusion of both iliacs, sometimes called the acute Lorich syndrome. There is no, here the other limb is filled by the collaterals, and is occlusion of both iliacs is called saddle-shaped thrombus. Patient presents with a manifestation of ischemia, and this patient sometimes presents with paraplegia due to spinal ischemia. So collectively, arterial embolism could be cardiac causes, arrhythmia, atrial fibrillation, myocardial infarction like mural thrombus, bacterial endocarditis, or non-cardiac like thrombus in an aneurysm, platelets thrombi on top of ulcerated atheromatous plaque on top of atherosclerotic vessels. As a pathophysiology, it starts by impaction. The thrombus impacted at the lumen of the artery, usually at the bifurcation, Then extensive or propagated thrombosis occur in the distal vessels, and then continuous thrombosis to more distal vessels, later followed by the muscle necrosis due to dead muscle, and finally gangrene with venous thrombosis. And this case is irreversible if there is complete occlusion of arteries and the veins with muscle necrosis. The commonest site of emboli is the common femoral artery, about 34%, followed by the external iliac, followed by the aortic bifurcation, and then the popliteal artery bifurcation, and then the other vessels. So the commonest site of embolism is usually at site of bifurcation. What about thrombosis? Thrombosis is occurring on an unhealthy artery or atherosclerotic artery. So atherosclerosis is the main cause or main factor of occurrence of this lesion or this disease or acute thrombosis. Atherosclerosis causes progressive narrowing of the arterial tree, as you see in this picture. This narrowing stimulates the development of the collateral. Here is the collateral development. And this importance because this collateral makes the picture of acute ischemia on top of atherosclerotic vessels or acute thrombosis is less harm than the acute embolic, but with a bad prognosis rather than embolic. All these factors lead to sluggish flow and leads to acute thrombosis in the distal vessels. If we treat this patient, we treat the acute phase only, but the chronic state is still present. So these patients, one of the patients that need more investigation by CT angio to know where is the level of occlusion or stenosis, and doing dilatation or doing bypass for this segment. This is to prevent the recurrence of this situation again. Clinically, how can differentiate between thrombosis and the embolism? Embolism, usually there is obvious cardiac source. Patient has atrial fibrillation, has irregular pulse, has another pulse, normal pulse on the other limb. This is very important, except if he is presenting bilateral ischemia. Thrombosis, there is no obvious cardiac source. Embolism, patient has no history of claudication, but in patient with thrombosis has history of claudication before the attack of acute ischemia. As I told you, maybe normal pulses in the contralateral limb if he presents unilaterally, while in thrombosis there is abnormal pulses in the contralateral limb. For the embolisms, there are few collaterals, while in thrombosis, well-developed collaterals. Also, the duration of symptoms in embolism, it has a more sudden onset, about 2 to 4 hours. Thrombosis takes a longer time, insidious relative to the sudden onset, but it is also sudden, not insidious. The aggravation of symptoms in embolism is very rapid, while in thrombosis is low. Claudication absent, here claudication present. Cardiac disease present, HENA is not present or may be present. The contralateral pulse is present, but in thrombosis may be absent if the patient has chronic ischemia of the other limb. Usually embolism localized to the site of bifurcation, while thrombosis may occur in multiple levels. Angiography show total occlusion with no collateral, while in thrombosis collaterals is present. Also, during the treatment, the thrombus is fresh in embolism, soft and fleshy, while in thrombosis the thrombus is sometimes whitish or milky or hard. Treatment usually by embolectomy, while in thrombosis the treatment is by thrombolysis, angioplasty or bypass to repair the chronic state of the artery. Like the clinical categories of chronic ischemia, we have clinical categories for acute limb ischemia, and this is very important for the management. How to deal with this patient? How can we treat this patient? Can we treatment by revascularization, or can be medical treatment, or can be more aggressive and doing amputation from the start in order to save the life of the patient rather than the limb? It is divided into 3 categories: the viable one, which is not immediately threatened, and irreversible. We start with the third one, which is irreversible. This is class 3. Here there is complete sensory loss, complete motor loss, no capillary filling. By Doppler ultrasound or Doppler examination, portable Doppler, there is no audible arterial or venous flow with major tissue loss. Major tissue loss means above the transmetarsal level, and the foot is not functionable at all. Here in these patients, the treatment of choice is amputation, because revascularization of this patient may end by other complication that may affect the life of the patient rather than his limb. So in this case, amputation is the best treatment. The first one, which is the viable, this is class 1. There is no sensory loss, no motor loss, good capillary filling, audible flow, venous and arterial, with minor tissue loss, means non-healing ulcer, focal gangrene, pain, and so on. Here in this patient, we can do either intervention or medical treatment. The second stage is the threatened or surgical, and this is the one that we deal it with surgery, either 2A or 2B. Here, the sensory loss is limited. The motor loss starts to be affected, either no in class 2A or mild in class 2B. Capillary filling starts to be sluggish. Arterial flow is inaudible, but still venous refilling, and tissue loss is minor. This is the threatened stage or class 2, either 2A or 2B, and this is the class of choice of intervention, either by embolectomy, surgical intervention, thrombolysis, and so on. Another revision of the clinical picture: we have pain, paralysis, paresthesia, pallor, pulsiness, and Persian coldness. Sometimes some authors add instead of 6 P's to a 7th P, which is purplish color of the foot, and sometimes they refer to 7 P's, not 6 P's. Here's the difference of color between both lower limbs due to ischemia. And here's the cyanosis of the distal end of the right foot, as you see the difference between the normal foot. So the first is the color changes. Usually we say that the patient with acute ischemia presents with one symptom, which is pain, and 5 signs, which is starting with pallor, pulsiness, paresthesia, paralysis, or Persian coldness. The first is the pallor. Start with due to dilatation of the vessels, paralysis of the capillaries, then filled with deoxygenated blood, lead to cyanosis, and then becomes permanent cyanosis, which is called the mottling. So start with pallor, then this discoloration, which is a mottling coloration. Also the second sign is the pulsiness. Pulseless, there is no pulsation, starting either from the posterior tibial artery, femoral, popliteal, or dorsalis pedis artery. The temperature of the limb is cold with slow capillary filling. Here is the starting of the color changes, cyanosis, which becomes later fixed cyanosis called mottling. This indication of complete paralysis of the capillaries in this area, and there is no, they are filled with deoxygenated blood. This is another case of mottling. Usually this mottling suggests irreversible ischemia, and this means they are dead tissues, and even if they are revascularized, this segment will not be revascularized and may lead to retrograde thrombosis of the whole limb, so it's better not to do surgical intervention in this area. Other is the paresthesia, starting with the light touch, and finally is the pressure sensation loss. Then for the movement is the paralysis. Usually the intrinsic foot muscle affected first, followed by the leg muscle. And usually the movement of the toes comes from the leg muscle. So the first movement to be lost is the plantar flexion or dorsiflexion of the foot, but the movement of the toes is lost late. So don't rely on the toes movement. Toes movement is a late sign. It is present even in a late stages of ischemia because it comes from the leg muscles. As you see here, the patient is asked to dorsiflex his feet at she has an ischemic foot drop of the left side. She can dorsiflex the right foot, but the left foot is not, and this is because the dorsiflexion comes from the leg. Dorsiflexion comes from the plantar muscles, while the toes movement comes from the leg muscles. Another changes of color changes with cyanosis and mottling and pallor coloration. Diagnosis of acute ischemia is mainly clinical, but sometimes we are in need for investigation, like duplex ultrasound, which is a standard for diagnosis, showing the thrombus, the nature of thrombus. If it is recent, this is hypoechoic thrombus. If it is late, hyperechoic thrombus, and so on. Second is the arteriogram. Sometimes we need arteriogram for diagnosis. If it is associated with atherosclerosis, if we know or want to know more underlying disease, and so on. Echocardiography, this is for the cardiac condition of the patient, because most of those patients are having cardiac problem like atrial fibrillation and so on. Laboratory studies, this is important preoperative and for the cause. For the cause, if it's patient-associated disease, and preoperative for preparation of the patients, or sometimes patient comes delayed with manifestation of dead muscle that may affect the renal function, so this is very important for diagnosis of the patient. A case of duplex ultrasound showing the occlusion of the common iliac artery with reversed flow. Here thrombosis embolism at the femoral artery. This is a CT angio showing acute limb ischemia. Usually with acute limb ischemia, sudden occlusion of the thrombus. Here you can see the embolus or the thrombus, the shadow of the embolus or the thrombus is here, and usually it is sharp cut of the CT angio, not tapered like the chronic ischemia. Another saddle-shaped thrombus with acute Loriche or acute aortic occlusion bilateral. But here there is maybe associated with acute thrombosis of the left side with some collaterals filling the vessels of the left side. This is the top of the embolus in the popliteal artery. This is a classical meniscus sign with total occlusion of the popliteal artery at the popliteal trifurcation. Another picture of acute limb ischemia at the SFA or superficial femoral artery with sharp cut of the vessel, as you see here. Another two CT angio showing the occlusion of the vessels. This is a thrombus, intraluminal aortic thrombus, and here complete occlusion of the distal, anterior, and posterior tibial vessels with acute thrombosis. This arteriogram showing bilateral occlusion of the superficial femoral artery with tapered end and the multiple collaterals. This means these multiple collaterals that the artery is occluded is a chronic state or atherosclerotic vessels with acute thrombosis on top. These collaterals, as you see, as if doing functionally bypassing the occlusion. So these patients may present with mild symptoms rather than the acute embolic without no collaterals. For the acute limb ischemia, this is here a scheme for the treatment. We start with heparin. Once diagnosed, heparin and pain management. This is very important. If the patient in stage 1, viable, no neurological deficit, or Rutherford 1, this we respond to medical treatment. Then we start digital subtraction, CT angio, duplex ultrasound. This is to diagnose the cause. And we do revascularization, whether thrombolysis, thrombectomy, or bypass, if not improved or not responding to the medical treatment. Stage 2, which is the main stage of intervention, Rutherford 2, either 2A or 2B, we did urgent revascularization with thrombectomy or bypass. Usually we do only ultrasound, we didn't do intervention, CT angio or whatever, because this patient is diagnosed easily and it's a critical condition, so time factor is very important for intervention. After revascularization, we had either underlying vascular lesion we will do revascularization. If there is no, this is medical absent. If there is present, we do either endovascular surgery or bypass surgery. For stage 3 Rutherford, with dead muscle, no sensory, with sensory loss, soft tissue loss, no audible arterial or venous flow, we did amputation. This is the acute ischemia class 2B, immediately threatened. This is the stage of our intervention in this situation. So scheme for the treatment, either immediate care by anticoagulation, analgesia, improvement of the perfusion, treatment of associated cardiac condition, or the second by surgery, either operative revascularization or amputation, and the third one is thrombolysis. For the embolism, the main line of treatment is embolectomy by what's called the Fogarty catheter for the acute thrombosis, either by thrombectomy sometimes, which is part of revascularization, or if it is completely occluded, we did a bypass surgery using synthetic graft or reversed saphenous graft, or by thrombolytic therapy using endovascular catheter thrombolysis. Here is the embolectomy catheter or the Fogarty catheter. It has different sizes according to the lumen of the artery, either 3 French up to 7 French. This is for the aortic and femoral graft or saddle-shaped thrombus. And this is for the common iliac artery, extending iliac artery. This is for the SFA, and this is for the tibial vessel. So it is according to the size of the vessel that having the problem. We did small arteriotomy, introduce the catheter, and then inflate the balloon, and then retract the thrombus later on, as we will see in a very short video later on. This is a picture of the surgical embolectomy, and this is a small video. Here the thrombus, introduce the Fogarty catheter, then we'll inflate the balloon, and then the balloon extract the thrombus through the arteriotomy, and this is the technique of the Fogarty embolectomy. If it is a recent thrombus or embolus, usually it is seen as fleshy red color, as we see here. This is recent thrombus. Sometimes if it is organized or delayed or due to thrombosis or on top of atherosclerotic vessels, it is like this. It is whitish, hard thrombus or well organized. Here is the Fogarty catheter after extraction of the thrombus from the lower limb. Here is the angio showing pre-operative intervention, complete occlusion with a sharp cut of the vessels, and here after revascularization by balloon embolectomy, complete restoration of the flow, and here is the difference. Here is the occlusion, and here is the normal vessels. Another method of treatment is thrombolytic therapy using thrombolysis, like streptokinase, TPA, tissue plasminogen activator. Very expensive, but sometimes have some complication like anaphylactic reaction or hemorrhage. And this is using a small catheter, and this catheter is introduced to the tip of the thrombus, and then start infusion of these thrombolytic drugs continuously for a long time with repeated angiogram until restoration of the flow, as you see. This is called the CDT or the catheter-directed thrombolysis. What's the indication of CDT or catheter-directed thrombolysis? For the viable marginal class 1 or 2A, recent acute thrombosis, usually not suitable for embolism or old thrombi. For the old cases, it is not suitable because this we have to increase the dose, which may lead to bleeding for the patient without dissolving this old thrombus. Also, it's not suitable for the embolism because embolic is very easily to be retracted by embolectomy rather than thrombolysis. Avoid patient with contraindication. What are these contraindications? If the patient has cerebrovascular stroke within the previous 2 months, active bleeding or recent GI bleeding within the previous 10 days, or history of intracranial or neurosurgery in the previous 3 months. What is if the patient is not treated? What's the complication of acute limb ischemia? It can be returned to chronic ischemia or leads to systemic manifestation like myoglobinuria or acute renal necrosis, cardiac arrhythmia, acute respiratory failure, septic shock, or local signs like muscle necrosis and infarction that lead to myoglobinuria and acute renal necrosis, cholangitis, or sometimes leads to compartment syndrome. Compartment syndrome may be the cause of the acute ischemia itself by trauma, hematoma compressing the vessels due to compression of the compartment, and sometimes it is a complication of delayed acute ischemia, and sometimes it is a complication of revascularization. So what is the compartment syndrome? Is increased pressure inside the compartment of the leg, leading to compression of the veins and the vessels. Patient presents with excessive pain or pain with passive movement, numbness due to mainly the first sign is the first web space affection due to the compression of the deep peroneal nerve, tense swollen leg, and later on there is absent pulse. But in compartment syndrome, don't wait for the absent pulse to diagnose the compartment syndrome, but we rely on the other signs, because if we wait for the absent pulse, this means it is a late sign, and so the muscles will be dead. So the compartment syndrome may be the cause of ischemia itself by trauma, fracture linked to hematoma, compression of the vessels, and this is treated by fasciotomy, or sometimes it may be a cause of delayed ischemia due to dead and necrosis of the muscle with swelling of the muscle leads to necrosis, or it may be due to revascularization of the acute ischemia but delayed. So this revascularization leads to necrosis and infarction of the muscles with tension inside the compartment, as you see this picture, swelling with bullous formation. But don't wait again for the absent distal pulse. What's the treatment of compartment syndrome? Is how to diagnose. Recognize the syndrome, then reduce the intracompartment pressure by fasciotomy. Here we do either the open fasciotomy or semi-closed fasciotomy. Fasciotomy here, if we did fasciotomy with healthy, good muscles, this is a good indication, and this is a good sign that the patient will pass. But if we did fasciotomy and find dead muscle or non-viable muscle with this mottling, this means the patient needs to be amputated, rather than the patient may complicate to systemic manifestation and respiratory and renal failure. And the last one, as you see here, the acute ischemia class 3, which is irreversible. If we find this patient with major tissue loss, wet gangrene, rigor mortis, fixed joints, area of fixed cyanosis, reversible mottling, this means this limb is dead. We cannot do revascularization for this limb. So the best treatment in this stage or stage 3, not to revascularize, but to do amputation to save the life of the patient, not to save the limb of the patient. This is the end of our lecture. Thank you and good luck.